I'm going to spend the next 30 minutes talking about atrial fibrillation and stroke management beyond anticoagulation therapy. So please stop me anytime and try to engage you guys as much as possible. Okay, so we're going to define limitations of OAC or oral anticoagulation for stroke prevention and non-CNS systemic embolism. We'll review the rationale and patient selection for patients for left atrial appendage closure device, explore some unresolved issues in left atrial appendage closure device, and how to deal with patients that come in who are on oral anticoagulation and have strokes related to atrial fibrillation. Okay, so atrial fibrillation is a prevalent and growing condition. There are estimates that upwards of 6 million people currently have it in the United States and expected to grow to 12 million by the year 2030. Generically speaking, if you have atrial fibrillation, your risk of stroke is increased by about fivefold. You can further define that based on the CHADS VAS score, but in general, that's what we say. And 1 in 6 strokes that come to the hospital or in general are actually related to atrial fibrillation. And it's certainly the leading cause of stroke of those patients that have undiagnosed etiology, what we call ESUS, or cryptogenic stroke. And patients that have a stroke related to atrial fibrillation are very high risk to have a recurrent stroke in the next 6 months. So this is a bit of a busy slide, but this is the latest AFib guidelines, the Heart Rhythm Society, ACC, HRS guidelines. And basically, the way we assess patients is not based on the type of AFib they have, but if they have the diagnosis of atrial fibrillation, whether it's paroxysmal, persistent, or permanent, we then go to their risk factors based on the CHADS VAS score, which is congestive heart failure, hypertension, age 65 or higher, diabetes, stroke, vascular disease, and or female gender. So if you have two or more of those and you're a male, then your annual risk of stroke is higher than 2%. If you have 3 or more of those and you're a female, then your annual risk of stroke is 2% or higher. That for us is kind of the hard line in the sand. If it's 2% or higher, we have a class 1 indication for anticoagulation therapy. If it's between 1 and 2%, then it's kind of shared decision making. If it's less than 1%, then anticoagulation is not recommended. A couple important things about the new guidelines. So direct oral anticoagulants are always favored over warfarin with the exception of mechanical valves or the exception of moderate to severe mitral stenosis. And secondly, aspirin and Plavix serve no role in prevention of AFib, stroke prevention. So whether they're high risk or low risk, there's no benefit whatsoever in putting your patients on aspirin or Plavix. So unfortunately, even though these are the guidelines and we know what we should do, there are challenges in terms of getting that message to physicians as well as patient adherence. So this is a slide demonstrating across the risk factors between 1 and 9 CHADS VAS score, the anticoagulation really peaks at about 50%. So some of that's probably physicians not necessarily thinking that their patients are having a risk for stroke, or they may think they're too frail or elderly, et cetera. But for whatever reason, physicians don't prescribe more than 50% anticoagulation for patients that otherwise are indicated for anticoagulation therapy. And then when we do prescribe it, less than half of patients are adherent to their anticoagulation regimen, and even worse so for warfarin. So we thought when the newer agents came to the market in 2009 that we would have much better adherence, but the reality is patients and adherence it's always going to be a problem. So at best, we would say 50% adherence with direct oral anticoagulants. And some of that's cost related, but some of that is just patients being stubborn. So that's the reality of it. So as I mentioned earlier, there is a conundrum. There's a lot of overlap between the risk factors for a CHADS VAS score. Again, hypertension, age, stroke, TIA. These are things that are going to place you at high risk for stroke, but they're also going to place you at high risk for bleeding. So there is a score that we use called the Hasbled score that can estimate your bleeding risk over the next 5 to 10 years. In general, if you have a high CHADS VAS score, you know that you also have a high Hasbled score and that the patient is going to be at higher risk for bleeding. So that is a challenge and a conundrum. You've got a patient who likely is going to benefit the most, but also is likely going to be the most vulnerable. So that is definitely a dilemma. So, and we know that these bleeding risks compound over time. You can look at the chart showing that your risk of bleeding, if you have a Hasbled score of 3 over the next 10 years, is going to be in the neighborhood of 50% risk of bleeding. So this is a real challenge that we face. So what can we do to address the challenges with stroke-related atrial fibrillation and the patients that may not be able to take anticoagulation for a variety of reasons? And this is where we're going to shift the talk to closing the left atrial appendage. So we know, dating back for many decades, that the left atrial appendage is the source of strokes and atrial fibrillation about 91% of the time. This has been shown by multiple autopsy studies and then also by transesophageal echo studies. You can see a pathological specimen on the top demonstrating a thrombus in the left atrial appendage. And then on the bottom there's a transesophageal echo. This is an echo probe placed in the esophagus, gets us a really good view of the back of the heart, and that little structure right here is a thrombus. So that's a clot, so that shouldn't be there. And so this is a natural home for blood clots when you go into atrial fibrillation. And we'll talk more about that here in just a second. So in general, the left atrial appendage, we all have a left atrial appendage. It's unique to each and every one of us. When you're in sinus rhythm, it's kind of a benign structure. It does play a role in volume hemostasis. It secretes atrial natriuretic peptide, which helps to diurese. It's also involved in lipid and glucose metabolism. It also is a very compliant structure, so it serves as a reservoir and allows extra blood to sort of pool there. It's twice as compliant as the left atria itself. It also has a contractile function to it. It's been implicated as being a source of atrial fibrillation, particularly the base of the left atrial appendage is proarrhythmic. But this area, as you can see, it's got a lot of pouches and trabeculations, and so blood clots like to tend to form in here. When you go into atrial fibrillation, it increases the risk of platelet aggregation, platelet activation. You have the famous Virchow's triangle where you have endothelial damage in a hypercoagulable state, leading to blood clots that tend to form primarily in those areas. They'll start off very small, and then they grow large enough to be able to break off and damage, whether they go to the leg or the brain or whatever, but certainly this is the source of most strokes. So this is kind of just a FYI slide there. So every left atrial appendage is a very unique structure. It's kind of like your fingerprint. No two appendages are exactly the same. We have sort of characterized some of these morphologically. The most common type of appendage is what we call the chicken wing appendage, and this is kind of noted right here, where you have this little area that goes upwards. I'm sorry, chicken wing is over here. Right there, yeah, the chicken wing and B, where it kind of juts anteriorly. The most implicated one in stroke risk is the cauliflower or broccoli, but in general, the reason I show you this slide is not to show you which one is a higher risk for stroke or not, but this is the challenge we have in trying to close these appendages, is they're not just a nice little neat structure. They come with many lobes, many different angulations. The orifice of the appendage can be an oval, it can be teardrop, and if you're trying to put a structure in there to close it, completely seal it, you can imagine that there can be challenges completely obliterating that space. So this is what we're up against when we're trying to close the appendage with Watchman or amulet device. So we've known for many decades that the left atrial appendage is implicated in strokes, and in fact, in the surgical literature dating back to the 1940s, they identified a couple of patients that had recurrent blood clots in their left atrial appendage, and they were able to eradicate those appendages. But over the years, we've struggled to close surgically the left atrial appendage. There's a challenge if you close the left atrial appendage, you incompletely close it, it actually becomes a higher risk for stroke. Or if you leave sort of a large gap between the base of the appendage and where you closed it, you basically have a new appendage that may also put you at risk for stroke. So it's really not been until the last 10 to 15 years where this device, the AtriClip, has really revolutionized the ability of surgeons to close the appendage not only as a freestanding procedure but also as a concomitant procedure, whether it's for CABG or valve surgery. But the ability to put this device on and be able to take it back off and put it back multiple times where you want to, the ability to not shear the appendage, and the ability to put it pretty close to the base or the circumflex artery has been revolutionary. So, and our surgeons do an excellent job at closing the appendages during surgery. And so the guidelines actually recommend that anyone who has a CHADS VAS score of 2 or higher that's going for surgery and they have AFib, it's a class 1 indication to have their appendage closed. So our surgeons are well aware of this, and they do a very good job addressing the left atrial appendage. There is a lot of interest at actually looking at closing patients that don't have atrial fibrillation, and there's an ongoing study just because patients that have open heart surgery have about a 40 to 50% chance of developing AFib in the postoperative state, and so this may allow us to deal with those patients that soon will develop atrial fibrillation. It is very important if you do close it to have an intraoperative TE and confirm that the suture line is obliterated. There's no flow in and out of the left atrium and left atrial appendage. And then also ensure that it's very close to the circumflex artery on transesophageal echo so there's not a quote-unquote new appendage. There is no data, unfortunately, for clipping someone with blood thinners. Fortunately, the data that was obtained in the Laos 3 study, 75% of those patients stayed on blood thinners. Now, I will say, had an excellent result about, this keeps going in and out. They had about a 33 in stroke versus patients that just stayed on anticoagulation. So there may be a role for simultaneous mechanical obliteration of the left atrial appendage plus anticoagulation over just anticoagulation alone. And I'm going to talk about that in just a second because that is actually a study that we're involved in. So endovascular left atrial appendage closure devices. So these are the devices that we deploy through the groin into the heart. 20 years ago, if you told me there were only 2 devices that would be FDA approved, today I would say no way, no how. But there are currently only 2 devices that are approved, and there have been a lot of interest in this over the last 20 years. So a lot of devices have come and gone. They've fallen off the market. They've had too many complications, too many leaks, too many blood clots on the device. And so currently there's only 2 devices that are approved, and that's the Amplatzer Amulet device, which is made by Abbott, and the Watchman device, which is made by Boston Scientific, and they are currently on their 3rd generation device. There is a device called the Conform device, which is a foam device that we are actually involved in a clinical study on that one. But again, currently there's only 2 devices that are FDA approved in the US. So these are the workhorses that we use. So who is a patient that is an appropriate candidate for the left atrial appendage closure device? So per the 2023 ACC-HRS guidelines, patients that have a CHADS VAS score of 2 or higher, and they have an appropriate rationale to seek an alternative to anticoagulation, and they define that as an irreversible bleed. So something that AVMs or something that you're likely to have a recurrent bleed from, not necessarily an ulcer that you've been able to identify, treat, and there'll be a pretty low risk to have it again. Sometimes I think that's easier said than done, but these are the guidelines, and they have a whole list of procedures that are reasons that what they consider to be reversible and irreversible. But I think it is practicing medicine, and sometimes it's hard to predict these things. And then also patients who are deemed to have high risk for stroke with the CHA2DS2-VASc score of 2 or higher, and also have a HAS-BLED score of 3 or higher. And so they're deemed to be a pretty high risk for bleeding, but haven't necessarily had a bleeding event yet. And these may be your patients that have recurrent falls, or patients that are taking other medicines like non-steroidals or aspirin or something like that that are going to place them at additional risk for bleeding. So a little bit of medical judgment used there. So that's a little bit different than the National Coverage Decision, which was a CMS publication in 2015, or excuse me, 2016, and they require a CHA2DS2-VASc score of 3 or higher, which can pose challenges for male patients that have a CHA2DS2-VASc of 2. They insist on it being 3, so there's a little bit of a dilemma there. And then they also have to be suitable for short-term anticoagulation, because these patients will have to be on a short-term blood thinner while the device endothelializes, so you don't get a blood clot on the face of the device. We've also, since this was published, antiplatelets are an acceptable alternative to anticoagulation after the implantation of the device, but historically, people that are on DAPT may actually have more challenges than people that are just on anticoagulation. And by DAPT, I mean like aspirin and Plavix, or aspirin and Belenta, or something like that. And then it's very important that the medical chart has a shared decision-making. So we actually engage a non-interventional cardiologist to review the chart, call the patient, have a telephone encounter with the patient, review the pros and cons, risk benefits, alternatives. And so the combination of those two, me assessing the patient and them assessing the patient, is required by CMS to be an acceptable patient. And they do come look, because I got an audit about this last year, and thankfully we had done it, so it was just a random audit. So just in a few seconds, I'll walk you through the Watchman procedure, and it's the same for the amulet procedure. It's basically done under general anesthesia. We access the right femoral vein using ultrasound. We advance into the right atrium and then cross over to the left atrium. In the left atrium, we then put a pigtail catheter and inject the left atrial appendage with contrast. We also have a transesophageal echo probe down to give us images during the procedure. We take an injection showing the size and the type of appendage that we're dealing with, and then we come up with the size of the device that we're going to use, and we plug that in there, and we make sure it meets appropriate criteria, and then you release the device. And honestly, that in a straightforward anatomy, it takes about 20 or 30 minutes. A tough one is probably an hour. Most people go home the same day, and they do quite well with minimal recovery. So as far as this, honestly, is probably the biggest challenge that we face, and this is what we're going to do after the Watchman or after the amulet procedure. These are patients you've identified that have challenges with bleeding, and now you're going to commit them to a term of anticoagulation or antiplatelet therapy. And so this is a challenge. So for the Watchman, it's oral anticoagulation for 45 days. Then we do a transesophageal echo at 6 weeks. If it looks acceptable, we don't have a peri-device leak of more than 3 millimeters, so a leak around the device connecting the left atrial appendage with the atrium. We don't want that, because then basically clots can form and still get strokes. We know peri-device leaks do increase the risk of stroke. And then we also want to make sure there's not a blood clot on the face of the device. So these manufacturers have, for many iterations, tried to figure out how they're going to put a foreign body inside the heart in the left atrium in someone who's got AFib, and it's not going to form a clot on it. And so that's a polyurethane fabric. It's a porous fabric, and basically it acts as a scaffold for your body to endothelialize, and that endothelial tissue takes time, but that's the purpose of bridging them with anticoagulation or antiplatelets after the procedure. So you would be doing your patient a disservice if you put a Watchman in and just walked away without any kind of protection, then you're going to end up with a blood clot. So anyway, so post-Watchman for 6 months of therapy, total. Post-Amplatzer, 6 months of DAPS, aspirin plus Plavix. Post-Lariat, this is one where you can get away with just aspirin. I'm not going to spend too much time talking about that. And then we talked about left atrial appendage clip. In theory, there's nothing inside the body. It's an epicardial procedure. You really should not need anything. But since the studies are not out there, they're currently not recommending to stop anticoagulation. I'll tell you that we do, but that's what the studies state. So. Okay, so the Watchman clinical data, this has been studied since 2005. There's been multiple studies over the years. There's basically a recurrent theme. This is the Protect Prevail 5-year study, as well as the Prague 17 study, which was comparing direct oral anticoagulants to the amulet or to the Watchman. All the other studies were done against warfarin. They're all non-inferiority studies. So basically, the take-home message is, occluding the left atrial appendage is non-inferior to anticoagulation, whether that's warfarin or direct oral anticoagulants. The benefit is derived from lack of bleeding events that's going to be realized over time. So if you remove the post-procedural bleeding events and the bleeding events that patients are experiencing while they're committed to antiplatelet or anticoagulation, and you look over 5 years, there's actually a reduction in intracranial hemorrhage, reduction in hemorrhagic stroke, and that translates into a reduction in mortality. So that's the main benefit. So equipoise with ischemic strokes, but reduction in long-term bleeding events. The Watchman is a very safe procedure. This is a post-market registry, over 66,000 patients, looking at the 7-day data, 0.49% complication rate, including 0.18% all-cause death, ischemic stroke 0.13, systemic embolism 0.02, and device embolization approaching 0%. So it's a very safe device. It's as safe as putting in a pacemaker, essentially. As far as the success rate, there's about a 98% success rate, which is, you're always going to have some challenges, some anatomies that are too shallow for this device. So there's always going to be some challenges, but 98 to 97% of the time, you should be able to get an acceptable closure for the patient and hopefully get them off the blood thinner in the next 3 to 6 months. So I just want to spend the remaining few minutes talking about this slide. So in the clinical studies, I'm talking about the Rocket AF study, the RELY study, the studies that got the direct oral anticoagulants approved. Patients had strokes in those studies. So we do not have a drug on the market right now that's going to completely reduce the risk of stroke for AFib-related patients. In fact, in those studies, there was a residual 2 to 3% risk of ischemic stroke over 2 years on average. So, and these were patients with medium to high CHA2DS2-VASc score. So what do you do with a patient that comes in that's been on anticoagulation and has a stroke? So a couple things. One is we know those patients are twice as likely to have another stroke versus patients that are oral anticoagulation naive. So these are a special group of patients that are super, super high risk for a recurrent stroke. So, and in fact, in a Swiss registry study, 36% of patients that had stroke from AFib were already on oral anticoagulation therapy. So now there may be reasons for that. Some of these may not be failures. Some of these could be patients have hypertension-related strokes, or they have carotid disease, or they have other kind of plaque in their aorta and so forth. So not all strokes come from AFib. If it is from AFib, is it really a failure or is it underdosing? There is a lot of literature out there showing that probably at least half of the patients that receive the lower dose of the direct oral anticoagulants are probably inappropriately dosed and should be on the higher dose. It could be an underdosing issue. We know compliance is an issue. Absorption of the medication can be an issue. For instance, with Xarelto, you have to take it with food or it doesn't work. Eliquis, you don't, but Eliquis is twice a day. So there's a lot of patient factors that play a role. But let's say in a perfect world, you've got a patient who's taking his blood thinners, as he should be, and he comes in with a stroke from atrial fibrillation. What are some options? Well, there is no data to suggest that switching that patient from Eliquis to Pradaxa or Eliquis to warfarin is of any benefit. So that's point number one. Point number two, there's no data to suggest that taking that patient who's failed that medicine and giving them a Watchman is also beneficial, because I showed you that the data shows equipoise with regards to ischemic strokes. However, where there may be an advantage is the Laos 3 study showed that when they surgically clipped the patients, there was a 33% reduction in stroke over patients who got clipped, stayed on OAC, versus the patients that stayed just on OAC. So there may be a role for mechanical closure plus anticoagulation therapy. And I would engage you guys to consider, we are actually part of the Laos 4 study, which is the Laos 3 study doing it with the Watchman. So we're looking at patients who have a CHADS VAS score of 4 or higher, have paroxysmal atrial fibrillation, and have had a prior stroke, or have a CHADS VAS score of 4 or higher with permanent or persistent AFib. So these are patients that have a residual risk of stroke. Honestly, they probably have a 10% risk of stroke over the next 5 years, a lot of these patients. So what do we do with these patients that have residual risk that we're giving oral anticoagulation to, but we know it may not be enough? So that's what the next chapter is. And mechanical closure plus oral anticoagulation may play a huge role in helping those patients. So I think that's it. So in summary, AFib poses significant stroke risk, which can be better defined by the CHADS-2 VAS score. Again, 2 or more for male, 3 or more for female, class 1 indication for anticoagulation. Patients and providers must strive to do better to get our patients on oral anticoagulation and be compliant. Left atrial appendage closure is safe and an effective alternative to oral anticoagulation for select patients. Challenges remain with post-implantation medication regimens. It's a real thorn in our side, putting these patients on antiplatelet or anticoagulation afterwards. Is there something the companies can do better to minimize the time on those medications? How do we reduce device-related thrombus? And how do we reduce leaks around the device? And again, LAA closure plus anticoagulation may play a role in your high-risk patients that have AFib. Thank you, guys. Happy to take a question or two. Yes, sir.
This is more of a public service announcement, but we can. So, aneurysms, AVMs are okay on anticoagulation, right? I'm just that's
No, sorry. I think
no. I'm saying that, right? I'm trying to decrease my clinic visits for patients who need anticoagulation. So, because I think that's a place where we overlap a lot.
Sure. I mean,
right?
to me, I'm not a GI specialist. When I see AVMs, it's going to recur. So, for the most part, that in my mind is an irreversible bleed. But I could be wrong. Yeah. But those tend to recur more than a peptic ulcer disease that.
Well,
again,
yeah, I would say
we defer sometimes to other specialists.
Yeah, but what we get a lot is a patient who needs to go in anticoagulation for their AFib and they have an AVM, or if they've ruptured, yeah, we're worried about it. If they haven't ruptured, I'm going to say this, and I think I mentioned this, and treat the AFib, right? They need to be on the meds.
Yeah,
I would never modify that AFib treatment based on the presence of that lesion.
Of course. But certainly the AVMs at some point will lead to interruption in anticoagulation. Likely they'll come in with bleeding.
2% a year.
Well,
right.
2% a year maybe overall, but certainly the ones that we see have a reasonable risk of bleeding.
This is why I get the clinic consults, right?
Yeah.
Yeah, and
Exactly.
but every clinic consult, I say put them on the anticoagulation.
Yeah.
Right, because they've got a definite problem with the AFib they need to treat, and they've got a potential problem with the AVMs or the aneurysms. The aneurysm is even less likely, based on size, but under 5 millimeters, it's going to be the same answer. So it's a good place for us to have it. But yeah, peptic ulcers, I'm more worried about that, frankly, than I am the AVM or the aneurysm. Right.
Right. No, I'm always more worried about strokes than bleeding. I mean, the thing about it is not all outcomes are the same, right? I mean, a bleeding event is not the equivalent as a stroke. So I think a lot of times a stroke is life-altering. Bleeding is often temporized and treated, and then you move on. But not all outcomes are the same. So not all negative reactions or adverse outcomes from those things are equivalent in my mind. So. Yeah.